Well, I'm back. I believe this will be our last 15 minutes together. Assessment of cognition and mentation. For the nurse, this is our checking our level of consciousness, which you guys do on your head-to-toe assessments with asking them different questions to check if they are awake and alert or if they're lethargic, obtunded, stuporous, or comatose. What is the scale we would use to check level of consciousness? Anybody know? That would be your Glasgow Coma Scale. That checks all of these and gives us a score. The Glasgow Coma Scale can be found on page 918 of your Iggy book, and it gives kind of a little definition of what it does, how it tests people, and what each number represents. We're checking eye-opening, motor response, and verbal response. You want to get a score of 7 represents a comatose state. The lower the score, the less level of consciousness the patient has. Orientation and awareness, you see this on your head to toe when you ask person, place, and thing. Behavior and appearance, how does the patient look? Does the patient act appropriate? Are they clean? Do they know that they're not clean? Is there a reason they're not clean, or is there no reason? Memory and abstract reasoning as well as language need to be assessed for aphasia. Ask a client to name different objects in the room or give a command, point to your nose. Something like that. So you'd say point to your nose and see if they follow your commands. Expressive aphasia is he understands written spoken words but cannot speak, write, that should be right, not just write or speak to communicate effectively. Receptive aphasia is they cannot understand written or spoken words. My sister, like I said, is a speech therapist, and she works with a lot of different aphasias and has working with patients who've had strokes and dealing with how to express themselves after a stroke. The mini mental status exam, I put one of these on your blackboard on how to run them. So it's a brief standardized method to quantify cognitive mental status, and it's used to aid in diagnosis of early Alzheimer's. It's used to detect impairment, follow the course of an illness, so we can get that baseline, see where the client's at, and then we do this exam maybe down the road a little bit, see how much they have progressed in their illness, and then monitor their response to treatment. So maybe we've put them on a medication like Namenda or something that's supposed to help decrease the progression of dementia, and we're going to check and see how that medication is working for them. So we would do the mini mental status on them. We've already got our baseline from the diagnosis. Now they've tried this new med. Maybe we see that they really haven't changed much. That's actually very good. That's a good medication. Assesses 5 areas of cognitive function: orientation, registration, attention and calculation, recall, immediate and short term, and language. You can try this on someone at home if you want. Like I said, it is on Blackboard. It's an interesting test. So there are different cognitive disorders. When I say we're assessing for cognition, what we're looking for. Dementia is probably the most common one. It's a chronic progressive disease of the brain. There's multiple cortical functions are disturbed. That means calculation, learning capacity, language, judgment, these different things can be disturbed. You have impaired cognitive function, decreased emotional control or social behavior and motivation, neurological disorder that affects ability to think, speak, reason, remember, and move. As it progresses, we get more into the unable to move. Usually it begins with just being forgetful, and then there's different stages of dementia or Alzheimer's. Alzheimer's disease is the most common type of dementia. It results in many possible changes. You may have seen a few of these at the long-term care facilities you're doing your clinical at, but you see personality changes, confusion, disorientation, even possible stupor, decreased intellectual ability, memory, and judgment deteriorate, as well as speaking can deteriorate. There are many possible causes, but the most common cause of dementia is Alzheimer's disease. There's vascular dementia, which is often after a stroke, and Lewy body dementia. We see this with microscopic deposits in the brain that we call Lewy bodies. We see these a lot in our Parkinson's patients. One of the things that we can do to prevent Alzheimer's, but we do not have a cure for Alzheimer's, is exercise appears to be most effective. Why do you think that would be most effective if you think about exercise? What happens when we exercise? What happens? We get more blood flow. Where does our blood flow? To the brain. So prevention is exercise, and exercise can also mean not only physical exercise, but mental exercise as well. Different studies have shown that older adults that do Sudoku or different puzzles keep their brain exercised as well. Alzheimer's disease is a progressive, degenerative, irreversible disease. Like I said, it has different stages. It starts usually with a physical health alert, subtle memory changes, personality changes. Things that you used to find easy to do are no longer easy to do. Stage 2 is usually the memory deficit. That's when you get a person who's wandering, or they forget where they live. They lose sense of time. And then we have the sundowning, which is when their personality changes as the day goes on, and changes in sleeping patterns and language deficits. Stage 3 is the inability to communicate, and even incontinence. And I say and even incontinence. They're not necessarily do they have incontinence. Complications can be pneumonia, which is one of the biggest complications that causes death in patients with Alzheimer's. Dehydration, malnutrition, falls, another big one, depression, delusions, and seizures. There are different medications and treatments that help decrease the progression of the disease, but it cannot stop or heal the disease. Those medications you may have already seen when you're passing meds, Namenda. We've seen already at our long-term care facility, Exelon, Aricept. There are possible benefits to the omega-3 fats, ginkgo biloba, and CoQ10 and others. I think Lisa will be proud of me that I threw in ginkgo biloba. There are different risk factors we can try to avoid when it comes to increasing our chances at getting Alzheimer's disease, and that includes diabetes. So you increase your risk to 65% by having diabetes. Genetic, apolipoprotein E. So if you have a father or a mother who had Alzheimer's and you wanted to pay an exorbitant amount of money to be genotyped and see if you carry the gene that increases your risk factor for Alzheimer's, the gene that they'd look for is the apolipoprotein E. Environmental, smoking and obesity, sedentary lifestyle makes sense because what did I just say? Exercise helps. So if you're smoking and you're obese, the blood flow is not getting to the brain like it should be. Exposures to fluoride, aluminum, and mercury can also increase your chance of Alzheimer's. A lot of people are saying increasing your chance of dementia or Alzheimer's includes drinking diet soda. So do I take that back up after Easter or not? But it does say that aspartame can increase your chance of Alzheimer's. Dietary risk are trans fats or deficiency of vitamin B6, folate, and vitamin B12. So what do we see at the nursing home as well? My group I know has seen it, where we are passing vitamin B12 to our patients. So maybe it's helping decrease the progression of their Alzheimer's. Something you could bring up at one of your med passes to impress your clinical instructors. Prevention and dietary benefits, the vegetables and the omega-3s again, wild blueberries, exercise 3 to 5 hours a week. Why wild blueberries? It's a potent antioxidant, so it does really help keep you healthy. And then challenge your mind daily. Like I said, patients who do Sudoku or crossword puzzles or who do challenging thinking games, there's even that new thing you can get an app, but you do have to pay for it, I found out, that you can do games daily that challenge your brain. Communicating with a patient who is confused, a lot of you have probably already done this. When you are working with a patient, you want to make sure you are face-to-face with them so that they can communicate socially with you. Also, seeing you speaking can help them, especially if they have any hearing disorder. Speak calmly, simply, and directly to the patient. And one of the big things that I noticed too, and I don't think I said anything to my students, but when you're working with a client and you ask them, do you know where you are, your date, the time, if they give you a wrong answer, say they think it's 1942, you should reorient that person back to 2014. So say, no, it's not 1942, it is 2014. Okay. Now we do talk about in health alterations when sometimes we don't reorient the patient back to different things. One of them being if they're asking where their spouse is who's died 5 years ago. We don't keep telling them they've died because they live that process over again and again. Reorienting them to time and place is fine, but we don't have to reorient them to their family member's death over and over again. Orient patient to time, place, and person. You'll see around the nursing home the big clocks, calendars everywhere, newspapers, TV, radio on. This helps keep the patient oriented. Communicate that the person is expected to perform self-care activities. So really pushing them to do as many of the self-care activities as they can, even if it's extremely slow. And offer explanations for care. So if you're grabbing their arm and putting a blood pressure cuff on it, don't do this without telling them what you're going to do. You want to explain cares. Because if they become angry, you're going to say, oh, it's because they have dementia, they're Alzheimer's. No, it's because they don't know what you're doing. So making sure that you explain cares can make for an easier morning for you, for one thing, but it also makes it easier for the patient as well. And reinforce reality if the patient is delusional. Communicating with an unconscious patient, this is really important, especially if you intend to work in any of the areas of the hospitals where there are vented patients or patients who are in comas or who have been placed in coma. Be careful what you say in the person's presence. Hearing is the last sense that is lost, so a lot of times they can hear what is going on around them. So keep the volume low as well. Talk in a normal tone of voice. You don't have to shout. And talk about things you would normally discuss. So in the hospital room, are we going to be discussing what our Friday night plans are with our other nursing friend? No, that's not proper. So you wouldn't do that even if the patient is unable to respond. And speak to the person before touching them, and keep environmental noises at a level. Even if a patient is in a coma, they can become hypersensitive and sensory overload, even if they are in a coma. Nursing interventions to maximize cognitive functioning. Stimulate all the senses, vary stimulation gradually. So don't do it all at once, because then we're doing that sensory overload. Vary stimulation gradually and use touch. Give plenty of time for responses. As we know, we would like to be able to do our head to toe in 15 minutes, but many of you have probably found it's a little bit hard to do in the nursing home because they're slower to respond, they're slower to take off that sweater for a blood pressure, they're slower to get back into bed to listen to that abdominal, to listen to their active abdominal. But you want to give them plenty of time for responses, and that can be verbally or even doing a head to toe. Use objects from the person's past. Ask them about the pictures that they have in their room and relate to experiences from their life, and emphasize patient strengths. So nice job. Good job with doing that. So emphasize those things with your patients. Possible nursing diagnosis. So here we go. You guys are all into your nursing care plans now. So anxiety when it comes to cognition, anxiety, risk for injury. Oh, what is this? Sorry. Anxiety, risk for injury, acute pain, deficient knowledge, impaired memory, social isolation, ineffective coping, disturbed thought process, disturbed sensory perception, that's a big one, caregiver role strain, and compromised family coping. Caregiver role strain you're going to see in the family members coming in to either see them in the nursing home or bringing them into the hospital. And they can become very overwhelmed. You think about spending a 24/7 time with one of the patients you're taking care of. It can be quite overwhelming. It increases physical demands as well as psychosocial stressors and economic stressors. They can lose their independence. Sometimes it can break up a family. So provide support. There's lots of support out there. A lot of the hospitals have support for caregivers. Any questions? Well, I can't answer them if you do, but you can email me. I am available, so if you have any questions on what we just learned today, please email me any questions. All of this can be part of your exam coming up, your exam 4, okay, as well as the final. So if there's anything you're questioning, please let me know. By the way, I hope you all have an excellent weekend, whether you celebrate Easter or not. I hope you have a great weekend, and I look forward to seeing you face to face again next week. As for my clinical students, I will see you on Tuesday, but the rest I will see next Friday. Have a great day. Bye.